Welcome, everybody. My name is Lauren Jost. I'm the project coordinator for the breast cancer program here at Washington University. And I wanted to start with a sincere thank you for being here and taking your time to hang out with us today. We truly appreciate it. And we want to start by letting you know, obviously, what the topic is for today. We have Dr. Lindsay Peterson, the Associate Professor of Medicine and a medical breast cancer oncologist, here with us, as well as Dr. Elizabeth Salerno, Assistant Professor of Surgery. And they are here to share their insights on living well with metastatic breast cancer, a focus on nutrition and physical activity. And we're also thrilled to welcome again Mr. Josh Newby, the founder and executive director of Teresa's Research, who will be moderating our town hall following our presentation today. This presentation will be recorded, as you guys most likely did receive a notification for that. I will cut the recording at the town hall, so no worries on being, I guess, seen or however you want to word it, for when I do put this up on our website eventually. We have some fun announcements. We have our upcoming support group. We had our first one past or 2 weeks ago in May, and it went over very well. If you are interested in attending, if you live in the St. Louis area, please feel free to scan that QR code and register through Siteman's webpage. Our next one, as you can see, is July 23rd from 5:30 to 7 in our Parkview Tower, which is in the Central West End, the Big Barns location. And we'll be working with a nutritionist from the Living Well Center. So that should be a fun evening where food is provided and a good time is also provided. We also have an upcoming, or the rest of our upcoming webinar series. So we have obviously today's, and then we have August, October, and December so far. So for for August, we have Dr. Catherine Wallbacher, who will be discussing bone metastases. So that would be a very interesting one. Feel free to scan the QR code. I will also send it out via email later on, and it will be advertised everywhere too. So if you miss the QR code, don't worry. There are other opportunities to register for it. And then, as I mentioned just a little bit ago, we have a web page that's going to come. We're hoping in the next month. That's the goal, which will have everything you could ever want regarding metastatic breast cancer and our initiative that we're working on here with that's Washington University. So again, more to come on that, but just a little fun. Following today's presentation and town hall, we have a survey as we did at our last webinar. We would truly appreciate it if you can take the 2 minutes, 3 minutes or so to complete it. It'll show up right in your web browser following the meeting. And then last but not least, we have a new email, which you may have noticed from the confirmation from the Zoom. It's Empowering MBC. I am your contact for the webinar as well as the support group. So if you have any questions or interests or just want to communicate about MBC, please feel free to email at empoweringmbc@woostel.edu. And with all of that said, again, thank you for being here and let's get started. So Dr. Peterson and Dr. Salerno, feel free to share the screen.
All right, thank you, Lauren. Let me get set up here. Okay, how's that look? Good?
Perfect.
Okay, great.
I'm
So
gonna disappear.
Dr. Salerno is going to disappear until it's her time. I'm Dr. Peterson, Lindsay Peterson. I'm a breast medical oncologist. I'm going to focus on the nutrition and weight management portion, which is why that's underlined and bolded, not because it's more important, but because I'm going first. And then Dr. Salerno will step in, introduce herself, and go through her slides. So for my portion, I want to talk about what we know and don't know about the benefits of a healthy diet, go over a few common myths about diet, things I hear in my clinic a lot, talk a little bit about supplements, which people also tend to ask a lot about, discuss some of the benefits and unknowns regarding weight management, and then define precision nutrition and go over some ongoing clinical trials. So one thing I want to point out is that poor diet, obesity, and physical inactivity have been associated with increased risk of cancer-related and overall mortality in breast cancer. But there are few data in metastatic breast cancer. So this is something that needs a lot more research. Dr. Salerno and I are both going to point out some studies that are specific to patients with metastatic breast cancer, but a lot of our data comes from cancer prevention and earlier stage cancer. So first, a lot of people, when they get a cancer diagnosis, say, what should I eat? What should I do? What should I not do? So one of the terms that you may hear a lot is is a plant-based diet. This is not a vegetarian diet, but it sounds like it is. And so the figure there shows you what your plate should look like. So you can see that the fruits, grains, vegetables account for about 75% of what's on your plate, and the protein only about 25%. So again, the protein doesn't have to be non-animal protein. It's just that the majority of what you eat should be plant-based, therefore coming from fruits, vegetables, and whole grains. Two of the national societies that put out regular recommendations on what cancer survivors should be eating are the American Society of Cancer Research and the American Cancer Society, which I think most people are familiar with. And so looking specific at diet, you can see that they do again emphasize that diet high in fruits and vegetables and whole grains. And we can just look at the American Cancer Society to make it easier. They also talk about essentially portion sizes, so choosing foods and beverages and amounts that help maintain a healthy weight. Again, getting that high amount of fruits and vegetables at about 2.5 cups per day, focusing on whole versus refined grains. And then a big one is limiting consumption of processed and red meats. These are things that have been known to be carcinogens for a long time. And in the very beginning, they thought they were mainly associated with GI cancers, but they do tend to be associated with breast and other cancers as well. And then we're going to talk about alcohol because this one, the different societies have a lot of different things to say about it. The American Cancer Society has taken a stronger stance and essentially said it's best not to use alcohol. Again, this is for cancer prevention, so we'll talk about the differences there. And then the AICR says if you're going to drink, to limit that to 1 to 2 drinks per day. So one thing I want to point out is that dietary patterns are often more helpful than macro or micronutrients. So macronutrients are your fat, your protein, your carbohydrates. Micronutrients are your minerals, your vitamins, things like vitamin C, selenium, etc. But diet is complex. So you're not consuming an individual micro or macronutrient. You're consuming those nutrients in the context of a food, which may be mixed within a meal with other foods. And how those things interact with each other is quite complicated. And so we can't really break it down on this granular level that I think a lot of times we would like to. One of the statements that I love the best and I think really captures this concept is that when we try to pick out anything by itself, we find it hitched to everything else in the universe. So true here and true in a lot of other places as well. So when we think about dietary patterns, this can be anything from the timing of when you eat to specific diet that you follow. I think most people are familiar with the Mediterranean diet as well as the DASH diet, which has been used really for hypertension. Something that may not be familiar to everyone is something called the Healthy Eating Index. So essentially what that is a scoring metric that's used to determine overall diet quality. And that was developed by the NCI in conjunction with the USDA based on the guidelines for nutrition. And it's extremely helpful to assess compliance with dietary guidelines, to monitor changes in dietary patterns, and also to evaluate nutrition interventions and education programs. And this is helpful, again, because of the concept above. When we look at some of the studies that have been done in the past, there's a little bit more data these days for low-fat diet in terms of breast cancer outcomes. But when we look specifically at those types of diets, so just high protein or high fiber, we really don't see any significant improvements when we focus with that level of granularity. And so we want to look more at diet as a whole in terms of diet quality, and this HEI index can be quite helpful. So if we look here, this is a graph, and I'll talk you through it, but essentially it's showing that a high diet quality is associated with lower mortality. So this NIH-AARP, the multi-ethnic cohort, and the Women's Health Initiative, these are all very large cohort studies of healthy people, however, many of whom went on to develop cancer. And so what it's doing is it's showing us that within these cohorts, if we look at who had a healthy eating index in the favorable direction, who followed a Mediterranean diet and who followed a DASH diet, all of these diets were associated with improved mortality. And that's true for all cause mortality, meaning death from any cause, cardiovascular disease mortality, which aside from cancer, we know this is one of the biggest risk factors for mortality. Also pertinent to cancer survivors who have had potentially cardiotoxic therapies, and then cancer mortality specifically. So again, it's unclear whether these types of diets significantly impact survival in someone after a diagnosis of metastatic breast cancer. But the way the studies were designed, overall, they are associated with improved outcomes. And so we can extrapolate that some of these patients did in fact have metastatic breast cancer. So we can't really label it a cause and effect and say 100% if you do this, we know you're going to get X improvement. But there is consistent large volume data to suggest that the healthier your overall diet is, the better your outcomes will be. So a lot of people say, how does my diet impact cancer to any significant degree? And it's actually quite fascinating and it can affect it on various levels. So one, it can impact tumor growth itself, specifically in conjunction with other medical therapies. And I point that out because even if in a lab, certain dietary changes in animals can impact cancer growth on its own, when we're talking about people, we really need to combine these dietary interventions with our standard medical therapies. We've never shown or expect to show that these dietary changes alone, without the incorporation of standard therapies, are going to be sufficient to treat cancer. The other thing it can do is it can improve your immune system, and that helps fight the cancer coming from a different angle. So a lot of people have heard of immune therapy. So the way we think about immune therapy is your immune system typically doesn't fight off your cancer like it would a cold because it doesn't recognize it as foreign. And so our immunotherapies help our immune system recognize it and attack that cancer, and it's now become another cancer treatment option that we have. So by improving the immune system, it essentially helps the immune system fight that cancer. Can also reduce glucose depending on the type of diet you're following, and tumors rely on glucose. So many people are familiar with PET scans. So when you get a PET scan, they're essentially putting a load of glucose into you. And when we talk about whether PET scan is positive or negative, whether it's there's a lot of uptake or not a lot of uptake, that's essentially telling us how much glucose these tumors are taking up. And so if we deprive tumors of glucose, then we can help decrease the growth or slow the growth down. The other thing that's really interesting and been shown more recently in studies is it can actually impact treatment as well, both in terms of the effectiveness of the treatment and also in terms of reducing side effects. So we'll talk a little bit more about that. But I think it's really important to note that this is not a hypothesis. There's a lot of good preclinical data and data in humans to show that we can improve various outcomes with different nutritional interventions. So a lot of people ask about fasting and the ketogenic diet. So what both of these do or have the potential to do is that they reduce available glucose to tumors. So just like I mentioned on the previous slide, these are both approaches to reduce the available amount of glucose to the tumor. The other thing it can do is it can slow down the growth of your healthy cells. And this is important because it can make them less vulnerable to cancer treatments and lead to fewer side effects. So most people are familiar with the concept that chemotherapy kills cancer cells, but it can also kill or impact healthy cells. And the rationale behind that, in a simplistic way to think about it, is that the faster your cells are growing, the more susceptible they are to being killed by chemotherapy. And so that's why chemotherapy works against tumors, because those cells are growing rapidly. But if you think about healthy cells that grow rapidly, like those in our GI tract, when those are impacted, that's when we get GI-related side effects, mouth sores, nausea, diarrhea, etc. And so by essentially putting these healthy cells into a quiescent state, making them grow slower because you're not feeding them the way they normally would be, you can make them less vulnerable to cancer treatments. The box there goes through different types of fasting because again, this is one of the fastest growing diets out there, and there are many different ways to fast. So I just wanted to go through a couple of these definitions. Intermittent fasting is episodic periods of little to no caloric consumption. So a very popular one out there is called the 5-and-2 diet. It's where you consume normal diet for 5 days a week, and then for 2 days a week you fast. You can also do that on an every other day pattern. Time restricted feeding is where you're consuming all of your calories for the day in a defined window of time. We usually don't recommend this be any shorter than 4 hours, and to be effective any longer than 12 to 16 hours. And then of interest, I think probably most interesting to our patients is the fasting mimicking diet. So essentially, this is a very well-designed diet that isn't restricting the calories as much, but it is producing or mimicking the state of fasting in your body. So you're still getting that reduction in glucose. You're still getting those healthy cells to slow down. And so you can get a lot of the same effects of fasting without the idea of literally not putting anything in your body for hours or days on end. Now, some of the evidence for fasting in terms of this being beneficial for cancer patients is that they looked at a study of breast cancer patients and they asked them, when do you typically stop eating at night and when do you start eating in the morning? And they found that people who tended to fast for more than 13 hours at night had better survival. There's also a very interesting study using a fasting mimicking diet for patients who had HER2 positive breast cancer. And it found not only did it reduce some of the side effects, but it also improved the response to chemotherapy. So again, there's lots of different data out there. And although a lot of this isn't definitive, we do have some consistent evidence out there of how it can help. Now, the one thing that I'll caution is that you should really only fast as part of a study or with your doctor's permission and input. And this is for two reasons. One, there are some medical conditions that make someone maybe not the best candidate for fasting. Fasting generally is very very safe and well tolerated, but we do want to be cautious with certain medical conditions like diabetes and others. Also, because the data is limited, we want to make sure that we're capturing all of the patients who are fasting to really make sure we're giving the safest recommendations possible. So I want to do a quick note on something I spend a lot of time looking at is something called advanced glycation end products or AGEs. And what this is leading to is to talk about how you can essentially prepare your foods in a way. So not just what you're eating, but how it's prepared to also put your body in the best position to be fighting cancer. So essentially what advanced glycation end products are, or they're molecules that are created in your body, and they're created naturally. We all have them. And it's essentially when sugar attaches to a protein or any other nucleic acid in your body, we call those glycated proteins. And those glycated proteins can get broken down and excreted into your urine, but they can also stick to your organs. And so for diabetes, these are the things that stick in the kidneys and cause kidney problems. These are the things that stick in the vessels of the eyes and cause vision problems. But what's interesting about this is not only do you make this naturally in your body, but your food can be a source of these AGEs. And how you cook your food can have a significant impact on the amount of AGEs that is in the food you're consuming. So that picture there of the pizza and the hamburgers and the French fries is exemplifying that fried foods tend to have one of the highest age contents of everything that we can eat. So how can you lower the amount of age in your food? Well, one is to prepare foods with acidic marinades like vinegar and citrus juices before you cook them. This essentially neutralizes a few things that lead to an enzymatic reaction that essentially increase the ages in these food contents. The other thing is we talked about, frying being bad for ages. So that's high heat, high temperatures, often prolonged periods of cooking. So you want to do the reverse of that. So preparing your foods with moist heat, so things like poaching, steaming, boiling, and cook foods at lower temperatures for longer periods of time, as opposed to higher temperatures for shorter periods of time, is going to reduce the age content in your food. And we've done a few studies looking at breast cancer patients and found that higher levels of ages consumed in the diet is associated with worse outcomes. And also, when we check the age levels in the blood, the higher the levels there, the worse outcomes. So this is somewhere where we have the potential, not proven yet, but the potential to impact breast cancer prognosis by changing not only what we're eating, but how we're preparing what we eat. So I mentioned alcohol is again something people ask a lot about. So it used to be, the recommendation used to be, if you drink alcohol, limit to 1 drink a day per women or 2 for men. And they really came from the old studies that would essentially, thought 1 drink a day was okay. So they'd ask people, do you drink more than 1 drink a day or less than 1 drink a day? And they found lower cancer rates in those who drank less than one a day. But further studies went on to show that any amount of alcohol is associated with multiple cancers, including breast. What a typical drink is 12 ounces of a beer, an ounce and a half of a hard liquor, or 5 ounces of wine. And I point that out because if you go to a restaurant and order a glass of wine, you very well may get 8 ounces of wine. So 2 glasses of wine may be closer to 3, depending on how much they're actually pouring for you. Now, what we don't know is how this affects cancer after it's developed. So it's very clear that alcohol increases the risk of getting a cancer. What's less clear is once someone has a diagnosis of cancer, does consuming alcohol in moderation have a significant impact on outcomes prognosis? So this is an unanswered question, and a lot of people ask about this. So the best advice we can give is that it's best to drink sparingly, if at all. But if you're going to drink alcohol, to do so in moderation along with the guidelines. So precision medicine, I think a lot of people have heard about. It's essentially not treating everyone the same. So looking, your cancer on paper may be the exact same as your neighbor's, but in reality, you're nothing like your neighbor. And therefore, everything within you can impact your cancer and your cancer biology. And so we use that to treat cancer precisely. We get genomic tests. We see what mutations are present in the cancer and we attack them that way. And really, we need to think of nutrition the same way. So, nutrients and the molecules that result from that going around your body are not going to affect you the same way they're going to affect someone else. We call that metabolic heterogeneity, and that can be impacted by a lot of things: your age, your other medical conditions. The gut microbiome is something that's getting a lot of attention right now. And so, to say that a high protein, low carb diet is best for you doesn't mean it's best for your neighbor. And so a lot of the studies now are focusing on how to bring precision nutrition into this whole realm of precision medicine so that we can give more personalized recommendations. And if you look back to the recommendations as they are, they're very vague, right? It's a plant-based diet, it's minimizing processed meats and sugars. But they're not personalized, and that's where the field is heading. There's a long way to go, but there is a lot of research in that direction. So to some myths, so a lot of people say, so I should avoid sugar and I should avoid soy and I should take vitamins, right? And my answer to those is no, no, and no. And the reason is, although sugar may, quote, feed a cancer cell in the lab, consuming the recommended amount of sugar has not been shown to be harmful. Now, the recommended amount is not a large amount, so we have to keep that in mind. But you do not have to cut sugar completely out of your diet. Soy, interestingly, is actually protective, if anything. People used to think because soy contains something called isoflavones, which are similar in structure to estrogens, that it would make a breast cancer worse. And in fact, it may actually block the effect of estrogen, competing for the same receptors. And so every study has either been shown that soy is not harmful or is actually helpful. And sources of soy are things like edamame and tofu and soy milk. And so 3 servings a day is what's recommended if you're looking for that protective effect. The other thing is that multivitamins have not been shown to improve cancer survival nor improve cancer side effects. So they don't make people feel better and they don't make people live longer. The only exception to that is if there's a vitamin that's been identified that you're actually deficient in. And in that case, we would certainly want to supplement that. But in general, the use of these remains controversial and in some cases is actually harmful. So, two incidences of this. One, there's a study with breast cancer patients and others receiving chemotherapy that showed patients using certain supplements and vitamins actually had worse outcomes. And that may be because of the unknown interactions with these vitamins and other supplements and chemotherapy. So we do caution, especially during chemotherapy. The other is that there have been studies looking at specific nutrients like beta carotene, vitamin E, and selenium, where they actually expected to improve cancer rates, and the opposite was found. So, again, this is why we don't recommend things without high quality evidence because sometimes the trials that we do don't actually confirm the hypothesis. So, we don't want to be recommending these. The other thing you have to keep in mind is that many supplements are not FDA regulated. So there can be things in the supplement that aren't listed on the label. So it's impossible to say that it's safe if we don't actually know everything that's in that supplement. I wanted to point out one super helpful resource. The website's there at the bottom. If you just search Memorial Sloan Kettering herbal medicine, you can find this. But essentially, you can type in any supplement you're thinking of using, any herb. I use black cohosh just to show you an example because a lot of patients ask about this for hot flashes. And on the left, you can see what will come up for under the patient view, which is what are the side effects? So stomach upset, rash, dizziness, nausea, vomiting. Maybe not worth it to try to help the hot flashes. But more importantly, in that little line right there, it says, although rare, a few cases of abnormal liver function, liver damage were reported. You can actually have liver failure from this. So it's not common, but it can happen. So these things people often tend to think of as completely benign and risk-free, and that's not the case. The other thing is, if you go to the physician view, they talk about drug interactions. So tamoxifen is a drug that a lot of women with breast cancer take, and there may actually be an interaction between the black cohosh and the tamoxifen. So this is a helpful website if you're thinking about taking a supplement. And then I just real briefly wanted to talk on weight and breast cancer. This whole talk, nutrition, weight, exercise, it's really hard to separate these out because so often all three are happening in conjunction with each other. And so when we do separate these out, we try to do a nutritional intervention where no one actually loses weight, right? Or a physical activity intervention where no one actually loses weight. So we can isolate what the actual effect is. But in reality, that's very difficult. Weight gain is extraordinarily common in women with breast cancer. It's one of the most frustrating side effects, I think. And up to 96% of people after chemotherapy are going to gain weight, with anywhere between 5 and almost 14 pounds being common. So, as a breast cancer physician, I know how frustrating this is to patients. It's very difficult to manage. But what we know is that fat cells, what we call adipocytes, they're not benign cells. They're very metabolically active. And they can impact not only the growth of the cancer cell, but the environment that the cancer cell is growing and spreading in. They can impact your insulin sensitivity. They can increase estrogen. They can also increase inflammatory and immune-mediated markers that can also be harmful and lead to cancer progression. So we know that excess weight in breast cancer is a challenge and something that can be harmful for people. And it's important because obesity rates are very high. So the black line on the smaller box there is the obesity rates rising in the United States from 1972 here at the bottom, all the way up to 2012. And if you look at the other graph, this is showing obesity rates in cancer survivors. It essentially mimics that. It essentially mirrors it. But if you look at more recent data, if you combine obese and overweight rates, you're getting almost close to 75% here in the United States. And it's estimated that in 5 years, over 50% of the entire United States, not cancer survivors alone, are going to be overweight or obese. So patients always ask, should I lose weight? So again, most of the data for this is not in metastatic breast cancer, but there was a study looking at physical activity and weight in patients with metastatic breast cancer who were receiving chemotherapy. This was not what we call a randomized prospective trial for these particular areas of interest. This was a chemotherapy trial. But what they did is they went back and they looked at those patients who received chemotherapy, who reported their weight, their physical activity, did those have outcomes? So again, we can't establish cause and effect, but it can give us some insights. In this study, they actually found a much higher rate of obesity in the in the study population than in the general population. However, there's no difference in survival and no difference in side effects, which is reassuring. In earlier stage breast cancer, there's a study where patients enrolled into an arm where they got nutritional and activity counseling with the goal of losing weight. And they found that they did, in fact, lose about 5% of their body weight. They had improved waist hip circumference, which is another measure of obesity. They also had improved biomarkers. We're still waiting on whether or not the weight loss did, in fact, show improved survival. But if it did, or if it does, then recommending weight loss for patients will certainly be something that we do. We do that now for general health purposes, but we want to be able to tell someone if it truly is expected to impact their cancer outcomes as well. So essentially what we're saying with all these guidelines is that you should be as lean as possible without becoming underweight. I'll let Dr. Salerno touch on number 2 with the physical activity. Avoid sugary drinks, eat lots of fruits, vegetables, and whole grains, limit your red meats and processed meats, limit alcohol, and then don't rely on supplements to protect against cancer. So I mentioned that there's not a lot of research in metastatic breast cancer for these specific nutritional studies, but there are some. So one is a whole food plant-based nutrition intervention in women with metastatic breast cancer. And what they're looking to do is to see if their dietary intervention reduces weight and also has a positive impact on inflammatory and hormonal markers such as insulin and different sex hormones. What they'd like to see is that there's a decrease in breast cancer progression, an improvement in survival, and an improvement in quality of life. So far, we've seen that this intervention has, in fact, reduced weight by about 6%. It improves some cardiac markers like cholesterol, does have some improvements in some of the sex hormones. There were no difference in tumor markers, but those tumor markers in these patients, incidentally, were normal at baseline, so we wouldn't expect to see much there. So yet to have the data in terms of the quality of life and survival, but that'll be something that will certainly be very interesting. And then another study is looking at the ketogenic diet in patients receiving chemotherapy with metastatic breast cancer. This study took patients and did a supervised ketogenic diet, which is sometimes important to actually make sure patients are achieving ketosis, which they'll need to do to have the benefit of that. And then they follow the supervised diet with a self-administered diet. What they found is that it was possible to achieve ketosis in both of these phases, that they did have a reduction in glucose and insulin, which are again associated with better outcomes, an improvement in body weight and body fat. And I emphasize body fat because a lot of times if patients aren't paying attention to strength training and their physical activity, much of the weight they lose is actually muscle. And that's not good. That's something called sarcopenia, which comes with a whole other host of problems. So when patients are losing weight, we want to make sure that most of what they're losing is body fat. And then finally, sort of as a segue to Dr. Salerno, there's something called the DREAM study, which is combining diet and exercise in metastatic breast cancer with a survival outcome. So again, we're not just looking at quality of life. We're not just looking at effects. We're looking to see, can we actually improve outcomes? So here's a few references for you. The myplate.gov is great. American Cancer Society is great. AICR. NCCN has various guidelines, including both survivorship and metastatic breast cancer guidelines, which are patient-friendly, and you can download those. Those can be quite helpful. And then finally, another quote that I love is the price of anything is the amount of life you exchange for it. So if we're going to be asking people to change their diet and lose weight, then I think they deserve to know what that's going to get them. And so that's why we continue working with all of these studies. So I'll take questions at the end and I'll turn it over to Dr. Salerno.
All right. Thank you so much, Dr. Peterson. It was wonderful. That was such a great setup and will save me some time on definitions and explanations. So that's fantastic. So I always like to start off these physical activity conversations by making sure that We go over definitions. There are so many times that we'll use the term physical activity and exercise interchangeably. And you'll probably even hear me do it myself. I'm not immune to that mistake. But these are two separate behaviors. And so it's important for us to talk about how they're different so that we can better understand the effects that they have. So physical activity is defined as any bodily movement by skeletal muscles that results in energy expenditure above your normal resting rate. So believe it or not, even though I am standing here, I'm gesticulating with my hands, that is actually a type of physical activity. Right? It's not the type that we often think of where we're in the gym and we're huffing and puffing, but it is still physical activity nonetheless. And physical activity can be grouped into a number of different domains. So there are different ways that we can be physically active in our daily lives. So there's occupational physical activity. As someone with a desk job, I don't get a lot of that domain of activity versus, say, someone who is a physical therapist and moving around and lifting patients and constantly on their feet all day. They would have very high levels of occupational physical activity. There's also transportational physical activity. So when you park and you have to walk, say 5 or 10 minutes from your parking spot into the office, or if you're biking to and from separate places, any sort of activity that we're engaged in to transport from A to B is transportational physical activity. There's also caregiving physical activity. So I don't know if any of you have children or grandchildren or siblings and you have to run around after them. If you are carrying hampers up and down the stairs, that is a type of household caregiving physical activity. Now, anything else that doesn't fall into those domains would be recreational physical activity. So that's if you are going out dancing with your friends, or you are going to go play sports, or you're going to choose to engage in exercise that we'll talk about next. And so a lot of the studies that you'll see for physical activity focus very specifically on that recreational lifestyle physical activity. So not necessarily occupation, not necessarily transportation, not necessarily household. So it's important that we think about these different distinctions because the implications of these findings can be very different because the activities are different. Now there's exercise, and this is a subset of physical activity. And the biggest difference is that it's planned, it's structured, it's repetitive. And perhaps most importantly, it has an objective, right? It has a goal, and that is to improve or maintain some component of physical fitness, which is our next definition. While physical activity and exercise are behaviors, fitness is a state, and that is a set of attributes that are either health or skill related. And there are different types of fitness that our physical activity and exercise behaviors can work on. So there's cardiorespiratory fitness, right? So how well our body utilizes oxygen as we're being active. That's most associated with aerobic physical activity, where you're huffing and puffing, where you're more endurance activity. You also can have functional fitness. You can have musculoskeletal fitness. So how well is an individual able to bend down and touch their toes, to walk up and down the stairs, to lift things and place them in high places, to carry laundry baskets, right? So there are many different types of fitness. And so again, thinking very carefully about the activity that we're doing, how does that then inform our goal, our end goal? What type of fitness are we seeking to improve? And then finally, I always like to talk about sedentary behavior. And this is reclined, seated, or lying position that requires a very low energy expenditure. And I think it's important to note that sedentary behavior and physical inactivity are two very different things. So somebody can be highly active. They also can be highly sedentary. And so sedentary behavior is a totally separate behavior. It has its own determinants. It has its own consequences. And so in this schematic here, you'll see that we want to be moving more along this x-axis to increase our physical activity so that we are reducing our sedentary time, because we only have 24 hours in a day and we're moving and ambulating throughout our day. And so there's only 24 hours to give or to get. And so we have to think about replacing certain activities with other activities. And now there are physical activity guidelines for all of Americans. That includes children all the way through the lifespan into older adulthood. And the current recommendations for aerobic physical activity are at least 150 minutes of moderate intensity aerobic physical activity, or 75 minutes of vigorous intensity aerobic physical activity, or an equivalent combination of moderate and vigorous intensity aerobic activity, which is terribly intuitive, right? And so we have to think about what is moderate and what is vigorous. How are we determining intensity of the activities that we are engaging in? And if everyone had a metabolic cart where we could hook you up with a mask and collect your expired air and give us a great objective reading on a treadmill of your cardiorespiratory fitness, your maximal heart rate, that's simply not practical in individuals' lives. And so we have to rely on some other proxies to give us an indication of how we're determining intensity. And it's relative, right? Going for a walk up a hill is going to feel very different for me versus my grandmother, right? That walk, that intensity might feel very differently to different individuals. This goes back to what Dr. Peterson was saying about precision medicine, and we need to be precise in our dosing of physical activity. And so what we'll often tell individuals is that you can use the talk test to determine how intense your current physical activity is. So if you're going for a walk and you can carry on a conversation, you can sing, you can joke, you can laugh, you can do everything you normally can do as when you're sitting on your couch at home, that would be light physical activity, right? And then when you start working a little bit harder and you can still carry on a conversation, but you probably can't sing, that's when you're moving into that moderate intensity physical activity. And then when you move into vigorous, that's when you can only get a few words out at a time. You can't carry a tune and you can't hold a conversation. So that's a nice metric that we often use when we think about how are we getting at the intensity of the exercise or the physical activity that we're engaging in. There also are physical activity guidelines for resistance exercise. And so the recommendation is muscle strengthening activities for all major muscle groups on 2 or more days per week. And so by major muscle groups, we mean our biceps, our triceps, our abdominal muscles, our core, our glutes, our quads, our hamstrings, our calves. So really all of our main muscle groups, our backs, we want to be targeting all of those at least 2 days a week. But perhaps the most important recommendation here is that some physical activity is better than none, and there are more benefits to be had with more physical activity. So these recommendations are from 2018. The physical activity guidelines are updated every 10 years, and they convene a roundtable of interdisciplinary experts with external reviewers to comb through the literature and update what's happened over the last decade in physical activity research. How can we refine these guidelines? And one of the biggest updates moving from the 2008 to 2018 guidelines is that activity can now be unbounded. And by unbounded, I mean there's not some sort of minimum number of minutes you have to achieve before that activity starts to count. So before in 2008, it was you have to go for at least 10 minutes of a walk before you start to benefit from that activity. And that's not the case anymore. You can get 2 minutes here, 5 minutes here, 20 minutes here. It's the total accumulation of our activity throughout our daily lives. And this is also where it's important to distinguish between a physically active lifestyle and structured exercise, right? So we talked about how they're different. They have different domains. And sometimes in life, after a cancer diagnosis, that structured exercise can be really difficult to come by, even though it's incredibly important. And so filling in those gaps with a physically active lifestyle, that could mean parking farther away at the grocery store, committing to taking the stairs instead of the elevator, if that's a possibility for you. And so there are different ways that we can benefit from both physical activity and from exercise. And so this schematic came out of the updated 2018 physical activity guidelines, really underscoring that concept that every move counts, right? So limiting our sedentary time all the way up to everyone who can, more is better. And so these 3 papers were published, they came out together in 2019. And this was after the American College of Sports Medicine convened a roundtable of international experts to update the evidence what do we know about physical activity, sedentary behavior, and cancer prevention and control? And so these three came out to update our evidence. And this last one here, led by Katie Schmitz, is really a call to action for clinicians to help patients move through cancer and really leaning into exercise is medicine. And so overwhelmingly, what we see is not only does physical activity prevent cancer to begin with, but it also can reduce the risk of recurrence, the risk of death, and possibly metastasis. And we also have some really nice evidence for improved health outcomes during cancer survivorship. And so the paper that was led by Kristen Campbell in 2019 provides some really nice exercise guidelines and prescriptions, essentially, depending on what outcome you're interested in. And so where the evidence is strong, where there is enough evidence that we can actually create a dosing and exercise prescription, it's for physical function, anxiety and depressive symptoms, cancer-related fatigue, health-related quality of life, and lymphedema. And so what these recommendations for cancer survivors boil down to is to avoid inactivity and aim to achieve the general physical activity guidelines for Americans. Again, that's 250 minutes per week of moderate to vigorous aerobic activity and at least 2 days of resistance activity. And then the schematic here, I know the font is small, but this is where we have strong evidence and moderate evidence, the outcome that an individual might be interested in, and for aerobic resistance or some combination, what type of physical activity, how much, how frequent do we have to do that activity in order to see significant improvements in some of these outcomes? So for example, if an individual is having a lot of cancer-related fatigue and they really enjoy resistance activity, then here you can go to this dose. That would be 2 times per week of 2 sets of 12 to 15 reps for major muscle groups at a moderate intensity. So we actually have some really nice exercise prescriptions where we have strong evidence. But you'll also see that there are some areas where we have insufficient evidence, right? And there are several outcomes on here where they didn't even make the cut because the evidence is so limited. And so that includes sexual function as well as cognitive function. That's an outcome that I'm particularly interested in, cancer-related cognitive decline, and how physical activity can be used to prevent some of these functional declines during survivorship. But what about metastatic breast cancer? And as Dr. Peterson mentioned, a lot of our recommendations for cancer survivorship are for prevention, they're for early stage breast cancer. But we do know that there are some special exercise considerations for individuals who have bony metastases. And so in this case, exercise has been found to be safe and feasible, but there should be some special consideration for routine assessments of muscle strength or endurance activities that involve the muscles that attach to or act on that skeletal site where those bone mets are, right? So for example, if there's a bony metastasis on someone's femur, doing an exercise that really acts on the quad muscle would be something that should be carefully considered and maybe needs some supervision, right? So that is a consideration. There also have been few human trials for exercise and outcomes in metastatic breast cancer, but the findings are rather equivocal. So you can see here these 2 studies, one by Jennifer Ligabell and one by O'Riordan, no change in functioning, no change in quality of life. Now, these were smaller samples. Another study led by Jess Scott showed that aerobic training was safe, but it might not be feasible. And interestingly, Pajaris found something similar. There were high dropout rates, but evidence for reduced fatigue and improved function. And so this is something that we'll circle back to in a few minutes. But I do want to talk about one trial that has wrapped up recently, and the findings are starting to come out. And it's really exciting because it is a trial specifically in patients with metastatic breast cancer who have a life expectancy of at least 6 months. And so this is called the Preferable Effect Trial. This is led by Dr. Anna May. She presented findings at a recent conference in Portugal earlier this year, and it was great to talk with her about working with participants who were part of this study and the benefits that they received. And so this trial was in 357 patients with metastatic breast cancer across 8 study centers in 5 European countries and Australia. And they were randomized 1-to-1 to either a usual care control condition or to a 9-month supervised exercise program. And the study team was primarily interested in fatigue and health-related quality of life. And when we talk about health-related quality of life, we mean someone's satisfaction with their life in different domains, in the mental health domain and in the physical health domain. And some measures will also include a social component. And so the methods, what exactly was this trial? And so participants engaged in supervised multimodal exercise sessions over 9 months. And so what multimodal means, right, is that there was both aerobic and resistance training as part of the exercise sessions. So for the first 6 months, the first 2/3 of the trial, each session was 1 hour long, 2 days per week. So that means we're up at about 120 minutes of moderate to vigorous physical activity. So getting up there close to those recommendations. Then for the last 3 months, there was one supervised session that was replaced by an unsupervised session. And so this is where participants were slowly tapered off to try to build autonomy and independence in being physically active on their own. I won't go into too much of a tangent on this. I'm a behavioral scientist by training, and physical activity is such a complex behavior. It's not simple like brushing your teeth, right? As I think I'm preaching to the converted here in the room when we talk about this. It requires a lot of planning and coordination. And it's not something simple to do. And so these trials that are grounded in behavioral theory and provide independence to participants is so, so important. And the supervision for these sessions were by qualified exercise professionals, so exercise physiologists, physiotherapists, PTs, located in community-based or hospital-based fitness centers or PT practices close to participants' home addresses, which is great. Another really nice feature of this trial is that they had live remote exercise sessions that were available using Zoom. So participants could hop on remotely and they could get some more exercise that way. And so what did this trial find? I want to draw your attention to the purple line here. And so quality of life is on the left-hand side. And we can see going from baseline to 3 to 6 to 9 months, so the beginning of the intervention and the end of the intervention. We see significant increases in quality of life in the purple line. Those are the individuals who are in the exercise group. And the asterisk there indicates significant between group differences, or BGD. So that exercise group had significantly higher quality of life scores that after 3 months. And then what's great is that those are actually maintained over the course of the intervention. Now for physical fatigue here on the right-hand side, again, that purple line, this is where we want to see that line go down, right? We want to see decreases in fatigue, and we do see that. And there were significant differences between the groups where the exercise group had lower levels of fatigue at 6 and 9 months into the intervention. And so this trial is really exciting. Over 300 participants, a 9-month exercise trial. I don't know if anyone has tried to corral humans over a 9-month period of time, but these trials for Dr. Peterson's studies in nutrition and us who are trying to do exercise trials, it can be incredibly challenging and it takes a really, really long time. And so to see these studies come to fruition is really exciting. And now future directions, you can see here that this isn't colon cancer. This is not breast cancer. It's not metastatic breast cancer. But this study was just published 9 days ago, and it has really made a splash. And so I wanted to talk about it briefly because I think it has important implications for breast cancer as well and survivorship. So this is one of, if not the first, is this the only first, Lindsay, exercise trial in cancer survivors looking at mortality, survival, recurrence as an outcome. Most of the evidence that we have comes from these large cohort studies. They're observational. We're just looking to see if individuals who happen to be more active over time, if they happen to live longer too, right? Whereas this is a randomized controlled trial, a phase 3 trial with randomization to see if over a 3-year period, those who exercise can actually reduce the risk of recurrence and live longer. And so this was in 889 patients with colon cancer called the Challenge trial led by Carrie Kernier up in Canada in over 55 study centers. Participants were randomized to either a health education control condition or a 3-year exercise program, 3 years. And the primary outcome was disease-free survival. So we're individuals surviving without disease present, not having a recurrence. And so the methods, participants received an exercise guidebook and support from a physical activity consultant for 3 years. And so the first 6 months, there were 12 in-person support sessions every 2 weeks and 12 supervised exercise sessions. And then in the second 6 months, these were combined. And then the last 2 years, they were monthly in-person or remote support sessions with some supervised exercise sessions. So again, really trying to provide that tapering and that independence and autonomy so that participants could be active on their own. The location, it was individualized. So again, this goes back to that precision medicine. Each patient was able to choose the type, the frequency, the intensity, and the duration of the aerobic exercise that they engaged in. And this is so important, right? We always talk about when we're prescribing physical activity or structured exercise to individuals, the best exercise is the one you're going to do and you're going to come back to, and the one that you enjoy. We actually see that enjoyment is a stronger predictor of behavior change than some of our other theoretical constructs. And you have to love what you do. My mom has been trying to make my dad a walker for 40 years now, and the man does not like to walk. And so we see in so many different instances, patients have to love what they do. They have to love the way that they're moving their body so that they keep coming back to it time and time again. And as a result here, we see at 60 months for that primary outcome of disease-free survival, our exercise group is the orange line here. There was over a 6 percentage point difference in disease-free survival with the exercise group at 80% and the control group at just shy of 74%. And so this is pretty striking for this type of a trial. For overall survival, again, we see over a 7 percentage point difference at 96 months. Now, the study team also looked at different health outcomes and behaviors. So did the exercise group actually increase their recreational? So, right, there's the type of domain of physical activity, moderate to vigorous activity, and they did compared to the control group. They also increased their predicted maximum volume of oxygen consumption. So their cardiorespiratory fitness. There was an increase there as well in the exercise group. Another proxy for fitness is this 6-minute walk distance, and we see significant increase in maintenance in the exercise group. And we also see improvements in functioning in the exercise group that at 6 months that is maintained, does drop back down a little bit as one would expect over 3 years, but it does stay significantly higher than the control group. And so where do we go from here? We need more randomized controlled trials in metastatic breast cancer patients specifically. And asking these dosing questions, precision medicine, what is the frequency, the intensity, the type, and the duration that we need across different outcomes to see some of these improvements, as well as the mechanisms of action. One of the benefits of physical activity is that the effects are so far-reaching and broad, but they also can be very selective based on the outcome that you're looking at. We see that for brain outcomes, brain structure and functional outcomes. And so what are the mechanisms through which physical activity is affecting health? Feasibility and acceptability are crucial. As we talked about some of those earlier studies where physical activity was found to be safe in metastatic breast cancer, but possibly not feasible. And so making sure that these trials are designed with patients in mind, right? Making sure that the value of the exercise is aligned with each patient's goals, right? We talked about all of the different types of activity we can do, the types of fitness available to improve, and what we're prescribing has to be aligned. And dyadic interventions here, that's where we have 2 individuals being targeted, may represent a prime opportunity to be creative and innovative in the way we deliver these trials. We know that when an individual is diagnosed with metastatic breast cancer, it's not just the individual who manages the cancer, it's the whole family, right, and support system. And so how can we pull more individuals into these interventions so that everyone is engaged and can improve their health outcomes? I will say that the exercise oncology field is booming right now, and so these are really exciting times to be answering some of these questions. I can't tell you how excited I've been to go to conferences over the last 5 to 10 years and see the representation of cancer and exercise across conferences that it was maybe one or two posters here or there, and now there are whole entire symposiums dedicated to it. And so it's a new frontier, especially with Carrie Kernier's new study in colon cancer and Dr. Anna May's study, the Preferable Effect Trial, really making some strides in having these phase 3 gold standard randomized controlled trials with exercise. And so coming back to what activity should I do, right? Every move counts, and making sure that it is the type of move that is aligned with what you are trying to get out of your exercise. So with that, I'll go ahead and pause and thank you all for your time. And I think at this point we are opening things up for questions. Thank you so much.